Hello, my name is Dan Levy, and I lead DMD clinical research at Pfizer. I have the privilege today to be speaking with Professor Francesco Montoni, who's a neurologist at the Great Ormond Street Hospital and University College of London. He was also chair of our steering committee for the CIFFREO trial, which evaluated the safety and effectiveness of our gene therapy, fortidistogene movaparvovec, for treatment of boys with Duchenne muscular dystrophy. He and I will be speaking about the results from this trial, which he just presented at the World Muscle Society in Prague. So welcome, Dr. Montoni. Next slide, please. Now, I'll introduce the first few slides around the design of the trial, and Dr. Montoni will share the results for both safety and efficacy from this trial. This was a placebo-controlled, randomized trial with fortidistogene movaparvovec. For every 2 boys who received fortidistogene, there was 1 boy who received placebo during the first year after entering the study. The study involved boys aged 4 through age 7 inclusive. And the schema here shows how the boys were randomized into the trial, the data that were collected over that first year prior to the crossover. And by crossover, that's the point after the 1-year data is collected, where boys who received placebo in the beginning of the trial then got gene therapy, and boys who received gene therapy in that first year received a placebo. Next slide, please. As for trial eligibility, as I mentioned, boys were aged 4 through 7 inclusive. They had been on daily steroids for at least 3 months, and they had North Star ambulatory assessment total scores at screening that were in a range that's pretty typical of boys with DMD at that age. There were some exclusions in the trial because of some safety events, which included specific mutations of the dystrophin gene that are shown here on this slide. There were also other exclusions related to pre-existing antibodies against AAV9, which is the capsid or the viral shell that contains the dystrophin gene, as well as prior treatments with gene therapy or any significant heart disease. Next slide, please. Now, the primary endpoint in this trial was the change from baseline at week 52 of the NSAA score, as comparing the gene therapy treated participants to the placebo treated participants. We also collected other endpoints, and key secondary endpoints of the trial included timed function tests at week 52, including changes of the 10-meter walk-run velocity or rise from floor velocity, or the skills gained or maintained on the North Star ambulatory assessment score. We also collected data on creatine kinase level, CK level, as well as the amount and extent of expression of dystrophin, mini-dystrophin. And of course, we collected data on safety. So I'm going to hand things over to Dr. Montoni now. As I mentioned, he recently shared these data at the World Muscle Society meeting. And if we can go to the next slide, he'll take over from there.
Thank you very much for allowing me to present this on behalf of all the investigators. As you indicated, exactly 2 days ago, I was in front of the World Muscle Society because Pfizer submitted this as a late-breaking poster or abstract, and it was selected for oral presentation. So I think that was received very well by the community because information on positive but also negative trials belong to the community. So this gives you a sense of the number of young people who could receive the AAV gene therapy, 64 versus 28 who received the placebo. And while I will not go through every single piece of information in this slide, I draw your attention that on the whole, the two populations were well balanced for age, for all other parameters you can say, from the race, the North Star score, the use of corticosteroid that you are aware are major modifiers. So the type of steroid, the duration of use of steroid, and so on and so forth, were well balanced in the two populations. Next slide. So this is unfortunately the result that indicates that at the week 52, the treated population that is indicated, if you concentrate on the left-hand side where it says overall population, you have that people receiving the AAV gene therapy in blue compared to the placebo. While there may have been a slight difference in the scores at week 35 that were modest, these were not present anymore at week 52. So that means that the people receiving the placebo and the people receiving the AAV gene therapy could not be distinguished for function at the age of 1 year. And then if you go on the right-hand side and you have two different graphs, one of individuals, of children who are below the age of 6 years, and one just below with the children who were above the age of 6 years. And again, there will be certainly identical almost shape of the trajectories of the children below the age of 6 years. There is minimal divergence at some time point for those individuals above the age of 6 years, but again, not distinguishable at the age of 52 weeks. So that, I think, indicates that with these parameters, there was no ability to detect an advantage of the AAV gene therapy. Next slide, please. And while the previous slide was of the North Star ambulatory assessment that I probably did not explain well, so that one was a functional assessment with a dedicated scale. This is the same, but this time with some of the secondary endpoints that are on the left-hand side, the 10-meter walking velocity, and on the right-hand side, the rise from the floor velocity. You would expect that, as an example, the blue, that the velocity is affected positively and by the AAV gene therapy, and similarly, the velocity to get up from the floor will be faster. But as you can see in this slide, there is essentially very, very similar slope and clearly no difference at the age of 52 weeks between the two populations. Next slide, please. So coming back to the primary endpoint, that was the North Star, there was also a pre-specified way to collect information that was one of the key secondary endpoints, that is in the various skills or in the various tests that are part of the North Star, there are individual sub-items, and these sub-items are divided by being able to do it normally, be able to do with some compensation, or not be able to do it at all. So there are 3 points. And it is a useful way of looking at, if there is a change, of course, what are the why there are changes? What are you gaining? What are you losing? Are you completely regaining a lost ability, or you're improving some of the ability, and so on and so forth? And this has been used also in other clinical trials. But I think, again, if you see on the center, there are the treated boys, the 64 treated boys. Only 63 had the data week 52, but that doesn't change the point. And the placebo, again, there should be 28. The reason why there were 23 is that these are the data at 52 weeks, not the entire population. But the bottom line is that the there clearly is not different, the percentage of gain or loss or improved skills between these two populations. Next slide, please. I think this is an important graph because measure the CK that many families will understand. And again, I draw your attention. In the blue, you have the trend of CK over 52 weeks in the treated boys. In the magenta, or there is the treatment, sorry, the level of CK in the untreated population. And I think you have on the left-hand side of the slide a decrease that is probably largely induced or significantly induced by the higher dose of corticosteroid that both boys in the placebo arm and untreated arm had, but this is transient. And in the placebo, clearly the CK level go back to the level. In actual fact, they increased by approximately 20-21% over the course of the 52 weeks, while there is a decrease of CK in the patient receiving the AV gene therapy. It is approximately 27-28% at the age or after 52 weeks. So suggesting that there is some effect, but this some effect clearly is not sufficient to drive clinical benefit for the patient. Next slide. And this is important because this is the question on whether those children who received the AV gene therapy and who also had a muscle biopsy, and you can see, especially I ask you to concentrate on the right-hand side where it says week 52, where you have, of course, the placebo individuals not having the any difference between the baseline and week 52. But those children the 12 children who received the AV gene therapy, having both, these are different methodology to measure the amount of dystrophin present, either the quantity of dystrophin using a particular technique that is called mass spectrometry, or the number of dystrophin positive fibers. And you can see on the top part, the between 85 and 92%, depending on whether you're using the mean or the median level of dystrophin with the first test, and on the bottom between 52 and 59% of dystrophin positive fibers, again if you're using the mean or the median. And this level are certainly in line, if anything, certainly not inferior to what had been identified by Pfizer in previous studies. Next slide, please. So this is a summary that of the safety that was observed. I remind you, for the colleagues or the families who may be listening, what things means. AE means adverse event. SAE means severe adverse event. And this therefore, and TEAE means likely treatment treated induced adverse event, treated related adverse event. So an important point to consider, if one starts from the big picture, none of the participants in the study died. However, not unexpectedly for people receiving AV gene therapy, if you take the treated patient compared to the placebo patient, there is certainly a significant higher number of treatment related adverse event in the patient who received the AV gene therapy. I think you have some of the wording is quite easy. Vomiting is people will realize what it is. Pyrexia means fever. GLDH increase is a marker of liver involvement. Thrombocytopenia means low platelets. That is, if you like, goes in a similar direction from the decreased platelet count, and hypertension is high blood pressure. So these were, if you like, certainly much more common in the people receiving AV gene therapy. But they are, again, not fundamentally different from previous experience using this AV gene therapy in this field, and certainly with previous studies from Pfizer. Next slide, please. So this is, I believe, my last slide, and is just to indicate that in the boys recruited in this study between the age of 4 and 8 years, the boy who received the active treatment did not have, at week 52, improvement compared to the children treated with placebo. That suggests that there is a significant clinical benefit for these children. This is both related to the North Star, that is the first that I've shown, followed by the rise from the floor, followed by the 10-meter walking test. The serum CK did decline. As I indicated, there was a lower level of CK in treated patient compared to the placebo. And there was indeed dystrophin expression in line with the expectation. But on the whole, that was not sufficient to induce clinical benefit for these treated children. And I think one of the last slides was on the safety event observed after receiving this drug, and that was very similar to the safety event and the safety profile of other AAV gene therapy, especially AAV9 gene therapies. I believe I'm handing over to you again, Dan.
Yes. Thank you so much for going through the data, and really appreciate your involvement as the chairman of our steering committee during this time. Let's go to the next slide, please. And this is just to remind me to thank all of the investigators who participated in the trial, but much more importantly, the boys who participated in this trial, as well as their families. This was not an easy study to participate in, both because of all of the visits that are normally required to receive gene therapy. And these boys had to do this all twice because they received placebo as well, and had to keep coming in for many visits, many blood draws, and really appreciate their commitment to this. Let's just go to the next slide, which is really just a prompt for us to begin our discussion, and we can make those the slides go away altogether, I think, at this point. Let me just begin, Dr. Montoni, by asking you. You had seen the data from our open label phase 1 trial that was available before we even started this trial, or as we were starting this trial. Well, were you surprised by the results that we had here, with an inability to show any differences on the key endpoints?
Well, yes, I think not only I, but many of us were very surprised. I'm sure colleagues at Pfizer will have been very surprised. And I think that the early clinical trial had suggested a indication of therapeutic effect. Then, of course, this is a big lesson for all of us, is the magnitude of what you find in small study may not necessarily be always replicated when you really start to move a therapy into the real world. And the phase 3 is a small step towards the real world. So yes, I was surprised, but I think that the most important thing for me does the study leave doubt? That would be almost worse. Because you will say, well, had we studied this and so on, and we measured that. But I think the study, it was well balanced and the data pretty unequivocal. So I think we probably, or it was the small patient population that was studying the early study, that probably misled all of us, as opposed to this particular study was not conclusive, and therefore maybe you need to do another study.
Yeah. Well, Well, thanks for that assessment. I will say that we at Pfizer were also very surprised by these results. We had seen the data at 1 year as well as at 3 years from our phase 1 study. And frankly, we're expecting to see real and meaningful differences between the placebo group and the treated group. And I'll say that we were very, very disappointed, not only for ourselves, but primarily on behalf of the patients with DMD, that we were not able to see such a difference. Amongst all of the data that you did show here, were there any particular assessments that were encouraging to you? I don't mean for that to be a leading question, and you did say that the results were unfortunately rather clear, but were there any signs of hope here?
Yeah, well, I think that the two, if you look at I think that from a close to clinics, the CK drop, I think, is a step in the right direction. It's not dramatic, but it's not completely flat. There is a more 45% difference between the 21 increase and the 27 decrease. So that, I think, there is a difference there. And the other thing that is encouraging, and this will be not specifically for you, but for anybody using AV9, the level of muscle expression that was achieved was pretty substantial. So that, to me, was the most encouraging one. I think that in a way, one will always ask the question on whether the subtle differences that was seen in different age range may underline a potential clinical signal in individual groups. And perhaps I will ask you a question on whether you have been able to go deeper into this, if you like, subgroup analysis, and whether there potentially is a group of boys in either or in the middle of the age range that was selected who potentially could benefit. So, so those are probably the area that are more the more interesting for the field as well. But I think, again, eventually the difference, you want people to get clinically, statistically, and meaningfully better after a year, and I don't think that could be achieved. But were there any difference that you think, by looking at subgroup, are more indicative of potentially a subgroup of people who may respond better?
Yeah. Thanks for that question. Well, you showed on the primary endpoint, you showed the results for the boys who, at the time of dosing, were either 4 or 5 years old versus 6 or 7 year olds. And unfortunately, we did not see any difference there in the primary endpoint. You didn't show it, but I think you and I have discussed the fact that the secondary endpoints, those time function tests, had also really no difference at 52 weeks in the younger versus the older boys. And I remember a few months ago when we shared the data with you, you had asked me about the creatine kinase and whether or not the boys who had the most profound reductions of creatine kinase versus those boys with the least reductions, if there were any differences there in the endpoints. And we examined that, and unfortunately, we didn't see any differences there. So, we also examined the possibility of any differences based on their baseline characteristics, such as the initial North Star ambulatory assessment score. We did not see any differences there. And so we have looked very hard to see if there is a specific type of boy who might respond better, and unfortunately, we just couldn't find anything. Now, that being said, we have heard from many of our investigators, and I have heard personally from some of the families in the DMD community that there were parents who felt very strongly that after their child had received the gene therapy, that there were clear and sustained improvements in their function. So what does that mean? Well, maybe it means that using these objective measures, these tests that we do in the setting of a physician's clinic, that we somehow still don't have the perfect test to really identify kids who might be getting better versus those who aren't. Perhaps it means that those parents who came up to me or came up to you or some of our investigators and shared with them just how much better the boys looked. And I know that investigators also said we had some boys that just my seeing them, I could tell they were doing better. Maybe those boys are the ones who tended to do better, whereas other boys receiving the gene therapy tended to do worse. It's really hard for us to tease through this, and we certainly can't say, unfortunately, we can't say that fortidistogene movaparvovec makes these boys better, at least at the 1 year time point. In spite of these observations that some of the parents have made, and maybe it's because some boys did better and some boys did worse. But unfortunately, just no ability for us to see any differences between the gene therapy treated boys at 1 year versus those who got the placebo during that first year. It's really too bad. Any other questions for me?
Yeah, I would be interested to hear, this was a randomized placebo-controlled study, so some young people would have received the placebo, and then a proportion of these patients at the time of transitioning to the active therapy arm they should have been receiving the active treatment, but the study was interrupted as soon as you had a signal of non-efficacy, I suppose. So the question is, what is the number of people who received the placebo the first time who managed not to get the active treatment before the dosing?
Yeah. In fact, there were about 17 boys, I believe, who received placebo at the beginning of the trial. And then because of the pause that happened in our trial in the spring, ended up not receiving their second treatment, which in their case would have been the active gene therapy. And then with the final results from our study, we made a decision not to dose any participants further. What I can say is that based on the kind of safety events that have occurred in the trial, and based on our inability to detect any objective benefit through this testing, we felt that it would be inappropriate to treat those last 17 boys. Now, I know that there will be some families who will be very disappointed, or who are very disappointed by that decision, but it was our view that because of the safety risks associated with this treatment, as well as our inability to show objectively any benefit, that we made the decision not to dose any more participants in the trial. what this means for those boys is that they will be able to enter other clinical trials. They will be able to receive other gene therapies as they become available instead of fortadistrogene movaparvovec. For example, if they receive fortadistrogene, then it's very likely that they would not be able to receive a potentially better gene therapy down the road. So this is why we came to that decision. And unfortunately, those boys who really gave their time and their exposed themselves to certain risks in our trial, why we have made a decision not to treat those last few boys with gene therapy.
No, thank you very much. I think that again, this to some extent is clinical trials, isn't it? Would be fantastic if we start a clinical trial. We could be certain that it will work very well at the end, but this is the risk to do clinical trial. And can I ask another question related to Pfizer has experienced a number of adverse events, including one fatal event in another study, not in this study. And the question is whether it will be, what are the learning, both for Pfizer, but for the entire community? Because these are, if you like, this is not the only program where there have been some fatalities. And I think we need to understand as much as possible what's happening to try to do a different job in the future.
Yeah, thank you. So just for clarity, I'll mention that overall in our program, we had 2 fatalities, one of which happened roughly 3 years ago, and we have spoken about that participant who died shortly after receiving the gene therapy. He was a 16-year-old young man with Duchenne. But you're referring to the boy who was about 3 years old when he received fortadistrogene, and I think he died about 15 months after his gene therapy when he was 4 years old. So let me tell you a little bit about him, because we have received some additional information since I last spoke about this. So as I mentioned, he was treated when he was about 3.5 years old. About 2 months after receiving fortadistrogene, he began having episodes periodically of rhabdomyolysis. I think that many of the parents are familiar with rhabdomyolysis, but it's an episode where there is injury to muscle cells that can be quite painful. And also leads to a release of the contents of those muscle cells into the bloodstream. One of those things that gets released into the bloodstream is creatine kinase. So the CK levels go up very high. And there is another protein that's released into the bloodstream called myoglobin, and that turns the urine red and can cause injury to kidneys. And one other thing that can be released into the bloodstream, because it's really in very high concentrations inside muscle cells, is potassium. So with that sort of background of what rhabdomyolysis is, I'll again, to be clear, about every roughly 3 weeks or so, this boy was having these painful episodes in spite of the efforts of the physicians taking care of him. No other participants in our trials who received fortadistrogene had anything like this. So we still don't really understand why he was having these recurrent bouts of rhabdomyolysis. And the investigators and some of their collaborators are working with us to still try and understand what was really going on in this boy. But if we go back to the day that he died, back in May of this year, he was experiencing what seemed to be a relatively typical bout of rhabdomyolysis, and he was brought to the local emergency room. And as I said, things seemed to be relatively normal, although in retrospect, or typical for him, I should say. But in retrospect, his laboratory tests did show very high levels of potassium in the blood, indicating that he may have had a worse kind of rhabdomyolysis event than some of the prior ones. And the lab tests, as well as the electrocardiograms, suggested that there was real toxicity of that potassium to his heart. He had an autopsy which didn't show any tissue injury, but the high level of potassium in the blood can cause the heart just to stop suddenly. And that's really what appears to have happened. Now, I will say that his death was, in this case, maybe not directly related to the fortidistrogen, coming 15 months later, but we do consider his death to be from the high potassium, which was caused by the rhabdomyolysis, which may have been related to the fortidistrogen. So this is a really very unfortunate case. We continue to try and understand this better with the investigators, and I know that they are planning on presenting a little bit more about this in the coming months as they continue to do work to understand the nature of the rhabdomyolysis in him. But anyway, I'm glad you asked that question, because I had really promised to the patient community that I would provide an update on that when we had more data, and I'm glad that we can use this video for me to share that information.
Thank you, Dan. I think that my another question I have that is partially related to what you just said, what data and what can be expected from those this particular study, the CIFFREO study, in terms of which data will continue to be collected, and will there be additional follow-up information for these families? I take from what you said earlier on that all families have received the information on whether they receive the placebo or the active compound, but I think that there continue to be some monitoring of these children.
Yes. So all of the investigators involved in the trial have been given essentially the unblinding information so that they can inform the participants in the trial whether or not they received gene therapy, whether perhaps they were one of those 17 or so boys who only received placebo. So yes, they should all be informed by this point. Well, let me first mention, and we've of course stated this before, but Pfizer has made a decision not to develop this medicine, fortidistrogen, any further. What does that mean? We are continuing the trials that are ongoing, although we're not dosing any more participants in these trials. But we have made a decision not to begin any further studies, and as I said, not to dose these boys, these last few boys who had not yet received it. Why did we make that decision? And I know that there are some families who are upset about this. Well, we reviewed all of our data with our steering committee, with our external data monitoring committee, with internal committees, and it was the view of these committees that overall, because of our inability to show any clear objective benefit, and because of the safety risks with the fatalities that we had and some of the other side effects and needs for hospitalization, that overall we would consider this to have more risks, more potential risks than potential benefit. So we did feel that the ethical decision was not to dose those other participants and not to begin any new trials and expose other patients, DMD patients, to this gene therapy when there are other ongoing clinical trials, both for gene therapy and non-gene therapy, that these boys could participate in and potentially have a better benefit profile versus risk profile. So that's really the reasoning behind our decision to discontinue the program. Now, that being said, all of the boys who were in our trials and who received active gene therapy will continue to be followed as long as they are willing, will continue to be followed in clinical trials for several years to come. Our primary focus is going to be on safety, and we are going to be most aggressively following for any safety signals. We are also going to track whether or not they maintain their ambulation in these studies. But because we know that we will not be developing this treatment further, our main focus is really on minimizing the amount of activities that we would require these boys to do as part of our trials. So we will not be elaborately testing endpoints as a requirement for the trial. If investigators in the trial or other treating physicians want to follow these endpoints, and we could potentially collect these endpoints in aggregate, that might be of benefit for our general understanding, but that's not really going to be required as we go forward. And we are in the process of amending our protocol to strip back some of the burdensome requirements in the trial. So that's, again, we want to ensure as best as we can, the safety of all participants and be aware of safety issues. But we are going to be simplifying our clinical trials as we go forward.
Thank you very much. I think that is very clear. And I think, again, the two of us have discussed that potentially this means that investigators, together with advocacy group and families, if interested, will still be of interest to collect at least some data in addition to the loss of ambulation and the safety as part of the clinic. Of course, this means mutual agreement, but I think there may still be things to be learned, and I think will be, if you like, this is still a unique opportunity to continue to collect as much information as possible. So there is as much learning for the future. Thank you very much, Dan.
Sure. And I am glad that we're able to take this time today to speak and for you to share with everyone the results. So really thank you for your time over these past several years, but also thank you for coming and speaking with me today. Appreciate it.
Thank you again.